Good afternoon, everyone. Welcome to the webinar, Data-Driven Practice in Postpartum Hemorrhage, hosted by the Office of Lifelong Learning Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher. I'm the Associate Dean of the office. Our office is committed to providing reliable updates, resources for clinicians, health professionals, and everyone committed to providing best clinical care for patients. I'd like to acknowledge that the University of Alberta, its buildings, labs, research stations are primarily located on the territory of the Niihau, Niitsitapi, Métis, Dakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So a little bit of housekeeping. Please use the chat feature on the bottom of your screen if you have a question about technical difficulties or L3PLP programs and services. If you have a question for our speakers, please use the Q&A feature on the bottom of your screen. Please review questions that have already been asked and upvote those questions you'd really like to see answered. We cannot guarantee that the panelists will be able to respond to all of your questions. As many of you know, a recording of the webinar will be sent via email to all of those that registered together with the Pros for Practice document. Participants can claim CME credits through completing a personal development activity using the My Lifelong Plan tool, which is a free tool. And for information, please visit the QR code on your screen or our website. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit as well. And Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today we're absolutely delighted to welcome Dr. Philippa Brain, she goes by Pippa, Stacey Nyl, Jeannie Yee, who will be highlighting the new information and tools for postpartum hemorrhage and showcase how data-driven practice can improve outcomes and strengthen postpartum hemorrhage management across Alberta. Pippa is currently a clinical professor in the Department of Obstetrics and Gynecology at the University of Calgary, and she's also the medical director for Women's Health Alberta, which includes an FTE for safety. She chairs the Foothills Obstetrical Aggregate Committee, reviewing severe maternal morbidity and mortality under the Calgary Zone Women's QAC. So this is an area near and dear to her heart. Stacey Nyl is a registered nurse and senior consultant with the newly formed Women's Health Program in Acute Care Alberta. She has a master's in nursing focused on education and a special interest in perinatal health system improvements and data optimization. So we can see how this came to be that Stacey's championing this work. And Jeannie Yee is a registered nurse with over 45 years experience in maternal newborn care. I'm not sure I believe that, Jeannie, 45 years. Like you started when you were 10. And she's the practice lead for the Provincial Perinatal Health and Clinical Transition Education. And she's responsible for needs assessments, development, delivery, and evaluation of provincial and Canadian interprofessional obstetrics and newborn care education programs and projects. So currently, she's the provincial lead for the FHS Canada Fetal Health Surveillance Education Program and a member of the FHS Canada Fetal Health Surveillance Steering Committee and co-chair of the FHS Canada Antenatal Fetal Health Surveillance Working Group. So just amazing to have all of you here today to do this education. We're so grateful to you. And I'm going to turn it over to your team.
Great. Thanks, Denise, for that warm welcome. I'll load up the slides and let me know if you can.
Working perfectly.
Perfect. All right. All right. Over to you, Pippa.
Good afternoon, and thank you for sharing your lunch hour with us today to talk about data driving practice, specifically in postpartum hemorrhage. I think most of you are aware of the Postpartum Hemorrhage project that we've been implementing province-wide. And this afternoon, I'm hopeful to show you some of the data that we have from past projects and some of the future goals. So today's objectives are, one, to showcase the optimization of provincial postpartum hemorrhage data collection and reporting, Connect Care workbench reports and Tableau dashboard. We'd also like to demonstrate how sites can utilize reports to support case reviews and target site-based quality improvement activities, as well as reinforce access and use of the existing resources, and introduce new resources available in the Postpartum Hemorrhage Toolkit. Next slide. So just a quick trip down memory lane, because this work has actually been going on for quite some time. And when I was site lead at the Foothills, we implemented back in 2019 a local QI pilot project, and I'm going to show you some data that we have as a result of that. And at the same time, this project was based on the California project and a modification of their work in postpartum hemorrhage. And the downstream part of that is to look at quality and outcomes. And so at the same time, we developed an aggregate committee through the a subcommittee, of the Calgary Quality Assurance Council. In 2021, there was a presentation of the project findings to the Legacy Provincial Committee. And at that point, a decision was made for provincial scale and spread as the standard of care. And then in 21 to 23, and we all know this, we had a Connect Care build and implementation across the province, but this has given us an opportunity to look at province-wide data and also implement province-wide programs, including the postpartum hemorrhage. And we developed resources for nurses, protocols, and launch of the implementation plan. And then the fall of last year, the province transitioned to women's health. And with that, we were able to implement evaluation and data optimization, as well as development of ongoing education, reporting, and a monitoring strategy. So here we are in November 2025, and we have a relaunch of the Postpartum Hemorrhage Reporting and Toolkit. We're going to move Postpartum Hemorrhage Implementation Initiative to sustainment and an ongoing process and outcome monitoring for quality improvement. And then we have future plans, and that is to continue using the postpartum hemorrhage data and optimize it for reporting structures for the operational side, as well as develop within this an obstetrical survey system based on the CANOS framework, which I'll get to in the next few slides. Next slide. So this is a very busy slide, but all to say that we actually rounded up this quality improvement project around implementation of the postpartum hemorrhage, and I'd like to share some of the data that we have related to that. Next slide. So when we have 2 years, or about 18 months of data prior to the initiation of the project, which was in March 2019, and then the subsequent 18 months or so following the implementation of the project. And we were able to show that the average number of patients receiving a blood transfusion per month decreased 16% after the postpartum hemorrhage project began, and approximately 3.7 to 3.1 patients. Next slide. We were also able to show that the average number of units of blood transfused per patient receiving blood decreased by 19% after the project began. Next slide. We also did a statistical analysis that suggested an increased correlation of 35% between the average number of blood cells ordered and the average number of blood cells actually transfused. So instead of arbitrarily just hypercrossing 4 units and potentially throwing away valuable units of blood, there was a better correlation when we implemented the quantitative blood loss. Next slide. We also looked at the total number of units transfused per month, and this also decreased by 17%. So in the development of this program, the second side of it was development of a dashboard at the Foothills. Next slide, Stacey. And this is the front page of the dashboard. And since then, we have now developed a provincial dashboard, which was based on this original one. And you can see that, and we'll be showing you the provincial dashboard live, that we can see the number of patients delivered, the number of the volume of blood loss at delivery, and so on. But next slide. Most importantly, the back side of this dashboard has an administrative side, that is linked to patient metrics. And that's important when we're trying to pull trigger cases for review for quality improvement. And this slide just shows you, I've glued off the actual patient identifiers, but we can toggle through this and look at the number of units transfused, whether or not they were admitted to the ICU, whether they had hysterectomies, et cetera. And that's been very valuable in implementing the quality side of this. Next slide. But because we have this dashboard, we now actually have quite a number of years of actual data to support the ongoing use of this project and how it's implemented some important change. So this is the raw data of postpartum hemorrhages at the foothills prior to implementation to the project. And you can see it hovers around about 11.75%, a little bit of up and down, but pretty consistent across the board. Next slide. Now that we've implemented quantitative blood loss and we can actually look at phase of postpartum hemorrhage, we can actually document what those rates are over time. So this is the data from 2019 up until 2025. And not surprisingly, you can see that the small volume postpartum hemorrhages increase. And that's because when you're not using quantitative blood loss, we tend to underestimate the amount of blood. But you can see that there's a fairly good consistency in the higher levels of blood loss, hovering between that 3 to 5%. Next slide. And when we correlate this data with the number of transfusions, we can actually see that when you implement the postpartum hemorrhage project, we're a much better correlation between those patients with high volume blood loss and their number of transfusions. And you can see a steady decline in that middle category, which is green on the slide. This may also be in part due to the implementation of an aggressive management of anemia in pregnancy, which also happened around this time. And we know that a hemoglobin less than 100 has a significant risk of needing transfusion at the time of delivery. And so aggressively managing anemia may also have been part in reducing the number of transfusions per patient. Next slide. So I previously was the co-chair of the Provincial Perinatal Quality Assurance Committee, which was reviewed all maternal deaths in the province, and Stacey and I worked together on that committee. But we have a robust amount of data in this province looking at maternal mortality, and this is over 30 years of data. And we know that hemorrhage is the #1 risk of maternal mortality in the province, which is consistent with national and international numbers. Next slide. But we also need to think about morbidity as a cause of significant safety concerns in delivering babies in both this province and across the country. And so it's not just about mortality, but it's also about morbidity. So maternal mortality rates have stalled in 133 countries and have increased in 17 countries, mainly in North America, Europe, Latin America, and the Caribbean. That for every person that dies giving birth, there are about 85 to 100 nearly die. And the consequences of these deaths and near-miss events are felt by families, communities, and health systems for decades to come. But these severe morbidities, excuse me, stories seldom get told and lessons are seldom learned. So next slide. As a result of this, there's a national initiative called CANOS, which is a multi-million-dollar funded grant that's centered out of both Hamilton and Montreal by two leaders, Rohan D'Souza and Isabelle Malheim. And myself and several other people in Calgary are members of the hub for this. And this is a quality improvement initiative that aims to go beyond the numbers to identify root causes of serious pregnancy complications. And postpartum hemorrhage obviously is one of those, among others. Next slide. So what are we actually doing in this project? We're essentially developing an obstetrical survey system or framework. So CANOS stands for the Canadian Obstetrical Survey System. And it aligns with most approaches that looking at severe morbidity or mortality across medicine. And obviously this is specific to obstetrics. And there's a 7-step approach, which is essentially following human factors methodology, where you look for systems improvements by looking at your outcomes. So the 7 steps include a topic selection and case definition. So in this case, we would be looking at severe postpartum hemorrhage. We have to have a means of identifying the case that we want to review. We need to look at those cases and do a case report through a standardized form and a local review. And then somehow this data needs to be centralized and gathered, de-identified, and recommendations made. Then there should be some form of external case review and feedback to the ground roots of the site, as well as hopefully to the patients and families themselves. Ultimately, a writing of findings and recommendations. And then through education, innovation, and quality improvements, we want to mobilize that knowledge and implement change. So how are we doing that when it comes to postpartum hemorrhage or severe morbidity in Alberta for these concerns? Next slide. So there's many frameworks published around the world looking specifically at obstetrical outcomes, the Embrace in the UK, California project, which I've also already mentioned in the US and other areas. And the triggers for review, and these are the triggers that are standardized for our terms of reference as we build this forward in Alberta, are more than 4 or more units of blood transfused per patient, an unexpected cesarean hysterectomy, ICU admission, and maternal death. And I don't think anyone would argue that those are significant morbidity. We've added to the list of triggers maternal readmissions within 2 weeks of delivery. And that's mainly because, it's particularly if you're transferring from a level 1 or level 2 centers to the tertiary centers, often the outcome gets logged to the tertiary center without the other sites necessarily knowing there's been a concern. And so if you look at maternal readmissions within 2 weeks or transfer to a tertiary site, it does allow for following those cases. HIE, hypoxic ischemic encephalopathy is a severe neonatal outcome. Another others would include RLS and patient complaints. And essentially, other can also include anything else that seems to cause concerns in the team, which might include other issues such as patient autonomy or lack of standardization of policies, etc. Next slide. So what about standardizations of forms? On the AHS Insight and to be in the Acute Care Alberta, there are standardized forms, and this particular one has been modified specifically for obstetrics. And in this box on the bottom refers to the SEEPS technology for patient safety, which is a way of making you think about the problem with a safety and system lens as opposed to a blame culture. Next slide. So in the SEEPS engineering for patient safety looks at tools and technology, and obviously Connect Care would stand out in this area. What organization, that could be things like, were there enough nurses on the unit? Were there enough beds? The persons who exactly were involved, what were their training and their specialty, the tasks at hand, and then the internal environment, again, might be related to beds. It might be that you had a flood. It might be uncontrolled things with the actual building or structure. And any concern with all of these can lead to processes that go awry and ultimately bad outcomes. And there are standardized forms which you can use to support this. And this is just a worksheet that's available with questions on the back that might prompt you to think of things that you might not have thought of otherwise. So for example, under person factors might be included competency, skills, training issues, personal goals, tools and technology, Connect Care, and many of the things that I've already talked about. So there are tools in place when you are reviewing these cases to prompt you to think of systems improvement when you make your recommendations. Next slide. And when you review these cases, it's important that we all speak the same language. And again, through AHS and safety, there are clinical rankings for adverse events. So a clinical adverse event is defined as an event that could or does result in an unintended injury or complication arising from healthcare management with outcomes that may include but are not limited to death or serious harm. Level 1, there is no clinical adverse event detected, which doesn't mean the reason that you were reviewing the case was a problem. For example, we're reviewing more than 3 units of blood, transfused, ICU admissions, death, etc. But it could be that everything was done completely right. So an example of that might be a mother that dies of a severe amniotic fluid embolism and a severe DIC where she was managed completely appropriately, and unfortunately she still passed away. That would be ranked as a level 1. Conversely, a level 4 would be an egregious error where definitely there was some systems improvement. And typically those level 4 ratings lead to a quality assurance review, which we also call a QAR or a core, however you pronounce it. So if we do these reviews and everybody is ranking the same way with the same intent, then it allows us to collect data and also to share outcomes and make recommendations. Next slide. So our Foothills aggregate data, which has been looking at those outcomes, every time we meet, we log what cases we've reviewed through safety. It's Section 9 protected. We look at and rank where we're at with the different triggers that we've used. And we may also add other triggers that may allow us to do aggregate case reviews of all of the cases that have been reviewed by our committee and others. Next slide. We then make a summary of the recommendations that we've done from our aggregate data. So we do a summary of the triggers. And ideally, there's a provincial oversight of the ratings 2 to 4. So those are those safety ratings where there were systems improvements to be made, with the potential for provincial recommendations as well as an implementation for either education or safety improvements, simulation, whatever it may be. Unfortunately, the PPQAC was stepped down with the realignment of Alberta Health Services, but I think developing this obstetrical survey system and the need for communication between different sites and zones within the province should allow, I hope, for a modified PPQAC that can still inform the women's health team of potential improvements and projects that could be implemented to improve safety in obstetrics. Next slide. Oh, you're 2 slides back, Stacey, I think. Yep, next one. So where are we at the moment? Okay, yeah. So there's the core of stakeholders that make up the team for which Stacey and I are both involved. There's a representation from patient safety. There's representation from research, as well as data and analytics who have developed the dashboard, as well as the IHOT team in order to help us implement and sustain the change. Postpartum hemorrhage has been implemented across the province, and we're going to show you some of your data through the dashboard. And we are at this point working on sustainment and reporting. We have done a provincial survey of present committees that are across the province because there are a scatter of these aggregate committees doing this work already. And we're hoping to standardize terms of reference for those committees and help develop ones where none exist, and use similar concise review forms, the human factors methodology to review, which is that SEEPS form I spoke about, and then the development of a formal reporting structure and oversight. And then like any sustainment or implementation of change, we need to socialize, train, re-socialize and train, and then continue to do webinars and follow up with good reporting to operations in ways that will be useful for ongoing surveillance. And we're going to talk about that through the next bit of the presentation. Thank you. So Stacey, I'm going to pass it on to you.
Perfect. Thank you, Dr. Brain, for sharing that kind of broad vision. I know with the Foothills pilot project, again, has definitely matured this work. And so I think it is really aspiring for us to say, okay, now that we've got this reporting structure in place, how might we even bump it up a level to that quality improvement? Jeannie and I are going to spend just a few minutes highlighting the PPH implementation optimization project. And with the transition to Women's Health PIN initially, and now the Women's Health Program in ACA, the project really had 4 main objectives. So we wanted to evaluate the initial success, the success, of the initial provincial spread and scale. We wanted to determine and identify gaps or additional support required for those sites that may need a little support in the implementation. we really focused on strengthening that data collection, reporting, and monitoring of the process measures and patient outcome measures. And we wanted to enable that monitoring and reporting to support the site-based quality improvement activities and move this initiative into sustainment. So I know this is a really busy slide, but it kind of nicely outlines the data optimization process. So we were, again, starting on the far left under the green here, under data collected. We determined the measures which we would want to basically have reported in Connect Care and or captured within a reporting system. And then move that into the measures captured. So then our patient outcome measures, so matching those, working with our digital health clinical systems improvement and our data and analytics teams to develop reports so that teams can monitor their data. So the reporting was really critical for this piece and what we implemented and included there. And then finally, again, moving it to that monitoring quality improvement. And really this process becomes iterative. One thing I wanted just to make note as is, again, because it's iterative, there's things actually in progress already that we're trying to optimize. Things like the use of tamponade balloons. So in the for future considerations box here, definitely they're including that because we want to include that blood loss as well. Again, things for consideration if we might want to track iron infusions, right? So again, we are on the road to making this more robust. So this is the Provincial PPH monitoring dashboard. And I just wanted to spend a couple of minutes looking at this. First of all, how to access. So I've got it saved, of course. I'm going to see if hopefully it opens nicely for me and that you can all see it. If you can't, I'll reshare my screen. Can folks see it or not?
I can see it, Stacey.
Perfect. Okay, great. So we're live here in the Tableau system. So if you don't have a Tableau account, you'll have to just sign in using your AHS email and register for an account just to, again, track your access. And so what you're seeing here is the PPH landing page. And in order to access this, all you'd have to do is to go to maternal and women's health first and even put in provincial postpartum hemorrhage, and that will come up just for folks to navigate. And then, of course, save it to your favorites. So I'll first start with the information tab. And this wonderful dashboard was developed by Alessia Barrett, who is our key partner in maternal child data and analytics. And so the information page nicely outlines the data sources, where she's getting and pulling the data from, the definitions so that everybody is aware of how we're defining each of the data elements. And really wanted to emphasize on this page is that we're pulling both the administrative data from Discharged Abstract Database and also NACRS, so the National Ambulatory Care Reporting System, and then also those really process measures in the moment from Connect Care. The thing about the data is that it's extracted and pulled and updated every 2 to 3 months. So you're not getting in real time data through this dashboard, but you're certainly getting a trending up until, I think, August has been the last update for this dashboard. All right, so I'm going to move first of all to the patient practice metrics. So your navigation is through the left-hand side here of the screen, and we've got the practice metrics up here, and this is Provincial. When we scroll down, we've got 2025. So we have up until the last, it'll be the last 4 months of 2025 that's not included here. You can see that it includes August. You're able to select sites. So if you want to just look at your own site, all the sites are listed here. And you're also able to not only select the site, but you can compare to other sites. You can compare to sites within your zone, or more broadly, based on level of care. So again, good for us to look at. Currently, we have, 33,000 plus deliveries. We have a percentage of PPH of 24.5. And as you can remember from Dr. Brain's wonderful slides earlier, is that we had an increase in the number of really those low-level stage 1 PPHs. And so even though we had kind of a baseline of about 12%, we were, again, grossly underestimating the amount of blood loss by doing only EBL. So now we have, this is about our provincial rate, and we're documenting our QBL in 83% of the cases. So we kind of want to, improve that over time as sites implement. One of the things I wanted to raise at this time is that with our evaluation survey of the implementation, rural sites with low birth volumes had the most challenges. Of course, if you're only having a very few number of births every month, then it's difficult to learn something new and to get comfortable with weighing and measuring the blood loss. So, but I would like to point out that if we flip back to 2024, we have definitely improved our QBL documentation already. So we've gone from 75% to 83%. So I think it's kind of nice to see that. The other thing, again, I'll just spend a couple of seconds talking about those process measures that have risk assessments, and we're getting a little better year over year, because that's part of the process, is to document the risk on admission, at full dilation, so just prior to that second stage labor, and then also 1 hour post-delivery, to be able to transfer and pass on that patient based on what happened during the intrapartum space. So we've gone up about 2%, so we have some room to grow there. It divides it by type of delivery. And then also we've got a bit of a relaunch strategy here so we can see how we're doing. And we really want to have a provincial target of about 80% and 90% for documentation of vaginal deliveries and cesareans. I'll just flip now to the patient metrics. And we can see, again, the number of patients that I identified with hemorrhage, not only for QBL, but remember by DAD diagnosis category. And again, it's by delivery method, by induction status, by the QBL. So to me, this is really demonstrative that we've got our largest category here is less than 500. And then our 500 to 1,000 is the mid-range here at 7.4%. And then our 1,000 to 1,500, 7.9%. And then our very tiny one, 4.8%. And on the right-hand side here, we've got our PPH patient outcomes, just to let you know, those are the first two. And you can, again, these might look familiar based on what Dr. Brain's triggers were for review. And so these are all cause. So just because they're low volume at the moment, these aren't only PPH readmits. And then your bottom category, so your bottom outcomes are related to PPH directly. As you can see, we've got 0.9% of patients with more than 3 bags transfused. So I think that kind of gives you a little bit of a snapshot. Again, I'm happy to chat about this later, but I think this is a tremendous achievement, and I think it's a great tool for us to actually be able to look at our site to see how we're doing at any given point. Okay, I'm just going to go to the Connect Care. So this resource that's on the screen right now is meant to support folks that need a little extra guidance for epic reporting. We have saved this document to our MS Teams channel, which we will include in the slides. We're going to talk about that in a few minutes. Um, and reporting user training is instructor led. And we really would recommend for you to take additional training in my learning link, because you may need an additional role in order to be able to access reports. But again, sometimes we took this training years ago, right, with our first implementation, and now it's like we're rusty. We're not really understanding how to, look at these reports and even slice and dice them. So there is training available to help you support that. The other thing I just want to let you know is that if and when you can access the reports, basically all you have to do is click on your analytics catalog and you type in PPH and you're going to get the 2 reports that are available. Again, you're going to get current inpatients for those kind of frontline providers. And then there's more the 30-day postpartum risk assessment and blood loss. So over that last month, which I think is really more valuable. So there will be more information and education regarding these reports as we're working with our digital health and CSI partners, and they will likely offer some additional support and training through virtual office hours. Just a little quick snapshot of something that you can do is in this report is to slice and dice. So for example, I sliced it by delivery method, and this is a level 3. This is a tertiary center. And you can look at the average blood loss as well. And so you get by each method of delivery and the amount of average blood loss. So again, you can slice and dice a million different ways, and you can get some great reports and download them, export these, and share them with your teams. Okay, at this point, I'm going to stop with the reporting pieces, and I'm going to hand it back over to my colleague, Jeannie.
Hi, thank you so much, Stacey. I'm just going to go over some of the new tools that we've developed that will complement the current tools we have. So what I wanted to bring forth is that we did have standardized resources that we have for our postpartum hemorrhage toolkit. It is available on our website. So there are actually 2 locations at the moment. They're still available on the MINCI website. However, as all of you know, Mincy has been stood down. And so we are making some preparations of moving, and we actually have completed the move of the Postpartum Hemorrhage Toolkit to the Provincial Perinatal Health website. And we will include both addresses on our notes that we send out afterwards. As Stacey mentioned, in preparation for this optimization project, we did an evaluation survey. And one of the key findings that we had was that people were not aware of our video shorts. So Maternity Minute Interprofessional, postpartum hemorrhage using the cone drape, and the maternity, thanks Stacey, video that looks at the quantitative blood loss is not well socialized. And part of the issue is that we developed them after we did our initial implementation in March. So we just wanted to point out to the people online that those are definitely available for you. We've had great response, positive response from the people who have used them. Can you go to the next slide, please, Stacey? The next one is our customizable resources. And Stacey had mentioned this earlier when she talked about the handout that looked at the My Learning Link courses for data. So in our customized resources, there are going to be a new one called the New Staff PPH Orientation Slide Deck. This is going to focus more on the sustainability of this project, as both Dr. Brain and Stacey has mentioned. That is not there yet. It will be available after December the 3rd. Also on this table is the dry weights table examples. We have the postpartum hemorrhage list, cart list. We also moved after the implementation equipment ordering to the customized resources because the pricing kept changing. So for example, on the equipment ordering, we have the ordering for the scale that we recommend that's able to weigh within a gram is which you would need for weighing for your dry weights. We also found that the purchase price of a cone drape vary depending on the vendor. So that information is also there. We'll keep changing that as we get more information. And then our massive hemorrhage communication tool is there. You can go to the next one, Stacey. Oh, I think this one's back to you, right?
You betcha. So now you're familiar with the current Toolkit resources and reports, and we'll share what tools are new and kind of just focus on key messages during the patient continuum of care. So one of the things that nicely, again, supports that patient support during these events is that we needed to strengthen the volume of the patient and family voice through this project. And so we had a great collaboration with engagement and patient experience. We recruited patient and family advisors to facilitate this patient journey mapping activity. They really vetted this, developed this, and helped us validate the themes that came through this activity. And the four main key messages were increasing prenatal awareness and education about postpartum hemorrhage, making sure we have clear and open communications with patients, partners, family members about the risk assessment, and then how PPH is actually managed in practice. We wanted to make sure that we included emotional support for patients and partners during and after a PPH event, and also that we have clear, specific discharge planning, monitoring, and follow-up. So this document may be helpful to review, to look at how we support the patient through the various touch points. And one, I think, a follow-up from this fantastic work was to make sure that we're including the supporting of the patient and family members in simulation examples. And so when we are, of course, stressed and we often practice the clinical pieces we need to run through, but it would be great to practice on how we support the patients in the moment. So I'm just going to cover this one area where you're familiar with the patient journey map. Let's focus now on the key messages for each patient care touchpoint. So for example, if you're caring for a patient prenatally, kind of towards the end, closer to delivery, we would suggest to discuss that PPH risk assessment that occurs in any admission, talk about prevention and management of PPH as according to clinical care. And they really indicated that they just wanted a little more information from their healthcare providers. This is not new, this information. This was included in the key messages of our last webinar series, but just really important that we're engaging in that active prenatal treatment of anemia. And certainly we've also linked that excellent resource on the hub, on the Pathways Hub. I'm going to hand over the next slides to Jeannie for the interpartum space.
Thank you so much, Stacey. We wanted just to highlight some toolkit tips within the interpartum section. We have the documentation of risk assessment. And as Stacey mentioned on her Tableau dashboard, we're looking at on admission, at full adaptation or the OR, and 1 hour post-delivery. Now, when we implemented the risk assessment, we were sort of in that in-between stage. We had some people that were still using paper because they had not moved to Connect Care, and we had it built in Connect Care. Now that everybody has gone to Connect Care, that risk assessment has been built into Connect Care, and you can use it during your assessment. So I think that's a huge improvement from where we were in March of 2024. The documentation of QBL at every delivery whenever possible. As Stacey showed you on the Tableau dashboard, we're doing very well. I just wanted to make a clarification, and it came out during our evaluation survey, is that you don't need to buy cone drapes to do QBL. It is nice to have cone drapes to do QBL because you can actually see visually how much blood is being lost. However, you do not need to have cone drapes because I know that's an extra cost. However, what is most important is that you do have a scale, and the scale needs to be one that can measure to a minimum of 1 gram. So the scale that we recommend is the Sika 334. I know there are still some sites that are thinking of buying some new scales. So if you are, please go to our customized resources on our MS Team page, and you'll be able to get the ordering information. We also found that as we work through a Connect Care, that we needed to do some revisions of the PPH order set. And we're currently working with Digital Health, and that order set will be coming out soon, and we will notify you when that is available. As all of you know, we have the Postpartum Hemorrhage Early Recognition and Management Protocol that assists nursing in the immediate care of the postpartum hemorrhage. Now, one thing I want to highlight is that we find, as Stacey mentioned on her tableau, that we're doing really well for risk assessment on admission, but we're not recording it very well on full dilatation or the OR or 1 hour post-delivery. So the tools I'm going to show you over this next few sessions, over the next few slides, were actually developed by our interprofessional working group that was established to review our evaluation results and to provide us guidance of what types of tools we should develop. So in response to how the risk score not being recorded at the different areas. And I really love this because I'm a color-coded person. So this to me is hits me very well. And we also felt that maybe people didn't know how to integrate your postpartum risk assessment score into the actual processes that you're doing during the care of the pregnant patient. And so you can see on this graph, we have a line for vaginal delivery, one for unplanned C-sections, and one for planned sections. So just looking at the vaginal delivery, you'll find that the yellow boxes are the processes you would normally do as the patient goes through the birthing process. And then the green one is the ones where you would do specific postpartum hemorrhage activities. And in particular, we have actually indicated when you would do it for your admission, when you would do it before at full dilatation, and then post-delivery. What a possible way of using this tool is for orientating your new staff. I would think that if you wanted to do that, you could print it off and put it into a pocket protector, and so that as you orientate them to the processes of what they need to do for carrying over the pregnant person, you can then indicate where the postpartum hemorrhage activities would be. And I won't go through the C-section, but this will be one of the tools that we will be putting on our standardized toolkit, which will be available after December 3rd. I think the next slide, Stacey. So this was very much a key resource, our postpartum hemorrhage medication table. We found that there were a lot of changes, so we needed to build a table and we needed to color code it. We knew when we built this, there was a lot of information on a small amount of space. So a lot of people were very innovative after we implemented. Some put it on legal paper, they laminated it, put it on their walls and so forth. But to address the concern of it being so busy and that they wanted more of an algorithm, we developed 2 tools. So the very first one, and we're calling them postpartum hemorrhage medication decision support tools. So you'll notice the very first line underneath the title, we still have a link to that table. So if you want more information, you get the table. This first decision support tool. We're calling it more detailed because it actually has the medication along with the route and the dose. However, we felt some people may wanted something even less. So we did it a basic tool, which was just listing the medications and having the algorithm follow through. So you will have a choice of which one you want to implement for your site. And those two tools will be on our standardized toolkit, also on our webpage. Think to the next slide, Stacey. So in postpartum hemorrhage. So if a postpartum hemorrhage occurs, and we need to provide patients with opportunities for questions and clarification. And I know we are encouraging patients to monitor lochia. Our PPH pad pictograph is widely used, and we've had a very positive social feedback on the socialization of this. However, we want to bring you attention to a pathway. It's called Bleeding After Pregnancy Pathway. This was developed collaboratively with Physician Learning, AHS, and the Primary Care group in Calgary. So I won't go through it, but certainly it's very well laid out, and again is another resource, and we will hopefully be able to also post that on our website. I think next slide, Stacey. Oh,
I lost my slides.
you lost your slides.
There we go. We're good.
Okay, to the next one. Stacey.
Back to me. So we'll just have a couple more slides left, guys, and then we can take some questions. Really, what we want teams to do, again, this is an interprofessional team sport. We want them to practice that implementation and documentation of the risk assessments and QBL for every delivery. We want for you to be able to practice responding to PPH in the different areas, labor and delivery, OR, PACU, and postpartum. And we have worked very closely with Provincial e-simulation and, of course, with Jeannie's team to talk about the availability and how to increase the availability of support for not just high fidelity sim, but more educational activities or simulation-like activities at again, more rural sites. We want you to keep monitoring that Tableau dashboard and the Connect Care workbench reports to monitor progress. You guys can make decisions regarding what quality improvements you need. Or if you guys are like, superstars, then, you might not need to attend to it. With support from your quality assurance and your quality councils, I'm not sure what the language is now. We want you to be able to review those cases of interest and those that have more severe outcomes with the objective of addressing health systems issues. So over the next year, Women's Health will be monitoring provincial progress at 6 months and 12 months post-relaunch, and we're calling this the relaunch. We're going to progress that PPH as the first provincial indicator to be monitored using the obstetrical survey framework, which Dr. Bray nicely outlined. We're going to continue to work with our digital health and clinical systems improvement teams to optimize the data. And we are also involved in an obstetrical education project where we're developing a framework that will support provincial interprofessional education standards. Over to you, Jeannie.
Okie dokie. And so over the next year, we know that as we bring out these new tools, there are going to be questions. And I also find that as we move through it and people use it, we may have suggestions of how we can improve them. And so the Provincial Perinatal Health Clinical Transition Education Team within HPSP will be working and being available to answer those questions and tabulate some suggestions of improvement. We will continue to support our teams with implementation, education advice, and facilitate access to simulation activities. And we do have a new email address, which is perinatal.health@ahs.ca, that you can send any of your questions or comments or suggestions to us. I think that's it, Stacey.
You bet.
Wonderful. Thank you guys so much for that tour of all the exciting things that have happened this year. We have a bunch of questions in the Q&A, and just to remind all the participants, please pop in the Q&A, put in your questions. Um, so Kayla and Carly are just bringing the midwifery voice into this question, and they're curious about a few things. So, strategies for how data from out of hospital births could be captured. Um, if there's any tools related to doing QBL with water births. So a few little nuances there, just to have you guys weigh in on how we might get that perspective in.
Maybe I can start the answer.
Sure.
So yeah, it's a good question around the capturing of data. So we have transitioned as part of the Women's Health Team Alberta, the former APHP database and program to requiring data coming from Connect Care, but obviously that's an acute care data system and doesn't address out of hospital birth. But it's recognized that there are some gaps both within that part of it, but also the ability to capture data that's required from Connect Care that is also still lacking. And that has resulted in us as the team at Women's Health developing a process for looking at optimizing obstetrical data in the province. When the original PIN structure was stood up, we had 4 priorities given to us. We're almost completing all of those 4, and the 5th one coming down the pipes was obstetrical data optimization. So we will be working with obviously the acute care sites, but obviously family practice, because midwifery actually falls under family medicine's program rather than the women's health program. And also working with the CSI teams and data analytics to optimize all of the obstetrical data, including those out of hospital births.
Oh, wow.
So
That's
that's a project in the works. It'll be just a short one, a week or so. Anyways, no, there's definitely some work to be done there, and we're fully aware of it. I've already forgotten what the second question was. Oh, about
the
water
water birth.
birth.
Yeah.
That's going to be a bit of a challenge, but I mean, one of the reasons to get a person out of the water is concerns about too much bleeding. So there is a certain error that goes with this. And there's criteria of safety for hospital births, which will be that PPH checklist prior to even deciding that you're going to have, not hospital, water birth. So I'm hopeful that those two things together can try and at least create some way of doing it. Sort of early recognition is the hope in doing the QBL from the get-go. So those people offering water births are going to have to develop some kind of early recognition process while they're undertaking that form of delivery.
Okay, awesome. Thanks, Pippa. Cassandra's wondering about whether or not there's any new updates to the medication table with the relaunch.
I'll take a stab at it, Stacey, and if you have anything to add, you can. At this moment, Cassandra, there is no changes to the medication table. As we mentioned, that there is a new Connect Care order set coming, and based on what the finalized order set will look like, there may be changes to the medication table. So if there's a specific medication or concern you have about that table, please feel free to send me an email and we can discuss it further.
That's great. Okay, thanks, Cassandra. And then one of the colleagues is just asking for some clarity on when the new tools and protocols are going to be launched. And I'm wondering too, as a relation to that, for the pearls document that's going out to the attendees, given that your stuff is changing where it's being housed, maybe you could share that so that when we send it out to everybody, they have that right to hand.
Yes, I think that's an excellent suggestion, Denise, and we will do that for you.
Yeah.
We actually just made the decision yesterday afternoon about where it was going to be finally housed. So that's why Stacey and I didn't put it into the actual formal presentation.
Okay, but we can include that on the
Yes,
pearls document, and everybody will
That's what I was thinking.
yeah,
have
we'll do that.
so that they can find it. They're not hunting for it. And everybody emailing you, Jeannie, where is it? I don't know what everybody emailing is saying, Jeannie, where did it go? Okay, awesome. Yeah. And
Totally.
so Angeline has a question here. She's thinking it might be helpful for frontline staff for Connect Care to auto-populate some of the elements around PPH and actions taken on the flow sheet tab. So wondering, and I think that kind of gets into like this is generally a flurry of activity, and the whole mechanical process of that piece, can that be automated to some degree or?
Yeah, it's a really good question. And I
Yeah.
think that's part of, the data optimization work that's still in progress to make it a little more smooth. There's also, there's the use of the maternal narrator, so where you're able to actually just document in one spot. And so I don't think it's easy to do. This is the short answer. It's not easy to do, but I think over time, we'll get better and better at the workflows and be able to address this because I totally get it. Things need to be more auto-populated and just driven, making it easier because the documentation burden is so high. Totally get it.
Yeah, and you know what? It strikes me that that's a really important human problem to solve.
Yeah.
So I know that there's just such a backlog on the Connect Care side with regards to some of these things, but I'm curious if there's a way, given Pippa, you were sharing that, this was a real priority for the PIN and this is a high priority area, maybe there's a way to sort of signal that this actually should be like pretty front and center on the queue of things to sort. Um,
Yeah,
you
I
know,
think that when we've sort of explored the process of Connect Care, obstetrical data optimization, one of the big issues is data going into the system. And at the moment, it's transcribed faxes for the majority of people. And I think that's going to be high on the radar. And then once it's inputted, it should auto-populate screens that require it downstream. So, and there's some efficiency that can arise from, document generation by just putting the data in and things like that. So I definitely think that's going to be part of our project charter going forward.
So interesting. It strikes me this might actually be a really practical application of AI.
Mm-hmm.
Um, you know. Oh, and Jenna, your question is being typed in by Stacey. So guys, we're like at 1:02. I just want to highlight the supreme timing of the team in executing on all of this. So much volume. So I know everyone has to get back to clinic, but just want to thank everyone for taking time this afternoon and thank, Pippa, Jeannie, Stacey for bringing this forward. It's so great. And thanks for letting our office help with the amplification of the work. And thanks to everybody in the background who's been supporting as well, Andrea and Natasha, etc. in the background. So thanks everybody.
Well,
Thank
thank
you so
you.
much.
Thank you.
Okay.
Real pleasure.
Take good care, everyone. Thank you so much for this work.